A junior doctor misses a prolonged QTC pattern on an ECG. A candidate blanks on axis deviation during a USMLE or an MRCP exam. And I've seen clinicians miss life-threatening diagnoses purely because they had no system in place. In this video, I'll teach you my personal 10-step framework, the same approach I use at the bedside, in the acute take, and in the exam hall. This system works. Trust me, it works every time. And my pro tip out of the 10-step approach is the step number 10, which I'm sure you would not want to miss. So let's build that skill right now with our MedEd quartet, Techie, Brady, AU and AG. So basically an electrocardiography or ECG or EKG called in the US is a graphical record of the electrical activity of the heart, which is captured by the physical electrodes placed on the body, on the torso or on the limbs. It's a non-invasive investigation, one of the best bedside investigations you can get on any patient. It's instantly available in terms of results. You don't have to wait for formal reporting or something coming out of the lab really. In terms of the electrical conduction system of the heart, there are two main pathways: the supraventricular conduction system, which is above the AV node, and that includes the SA node, internodal pathways, and the AV node itself, and the infraventricular conduction system, which is below the level of the atria and the AV node. So that includes a bundle of the bundle branches, right and main left bundle branches, and then finally the Purkinje fibers, which eventually transmit the electrical impulses up to the myocardium. One of the first things you need to know is about the calibration and of the ECG paper. So the horizontal grid and vertical grid. The standard ECG machine speed is 25 millimeters per second, and the vertical gain is 10 millimeters per millivolt. So if you look at the horizontal axis, one small box or one small square represents which is 1 millimeter in width, represents 0.04 seconds. So if you multiply by 5, so 5 small boxes which make one large box will be 5 millimeter or 0.2 seconds, so 1/5 of a second. That's why 5 large boxes will become 0.2 into 5, which is 1 second. And if we have a rhythm strip of 15 large boxes, that would indicate 3 seconds. So it will have a bearing on how we calculate the rate later on. In terms of vertical grid, you have a gain of 10 millimeters, which is 1 centimeter, equivalent to 1 millivolt. So one small square, one small box is 1/10 of a millivolt, and one large box, which is 5 small boxes, is 0.5 millivolt, and 2 large boxes with this analogy will be 10 millimeter or 1 centimeter or 1 millivolt. So these are some of the standard things that you have to memorize, these numbers, both horizontal and vertical grids. And it will have consequences of how we calculate the rate and rhythm, and also the different waveforms and shapes and intervals down the line. Just a quick word about recording the 12-lead ECG. So before you start, patient's informed consent, explaining the procedure, supine positioning, nice and relaxed so that muscles do not twitch. Let the patient rest for a while if they've been working for a long time to reduce, the resting heart rate, etc. And then ensuring good skin contact, whether it needs shaving of the chest wall, hair, or using proper adhesive sticking in the contacts. Then remember the color mnemonic for the limb leads. Limb electrodes. 4 limb electrodes. Ride your green bike. Right arm is ride, and then your is yellow. So the red is the right arm, yellow is for the left arm, green bike. So the green color one is for the left leg, and the black one is for the right leg, which is the earth or ground or neutral one. V1 to V6 chest electrode placement. Remember 2 intercostal spaces, 4th and 5th. 4th intercostal space on the right and left is V1, V2. Let's forget about the V3 for now. Then V4, V5 and V6, they come in the 5th intercostal space in successively mid-clavicular line, anterior axillary line and mid-axillary line. So V4, V5 and V6. So between V4 and V2 sits the V3. So V3 you just place in between the both V2 and V3. So this is the chest electrodes. So 6 chest electrodes, 4 limb electrodes, 10 electrodes. These are the physical wires, electrical electrodes. They generate a 12 lead ECG. We'll come to that in a short moment. So a normal ECG is made up of waves, segments and intervals. The pure waves are P wave. Then there are 3 separate waves, Q, R and S, which combine to form a QRS complex. We'll come to that later. A T wave, and then in pathological conditions you might have a U wave. So these are the waves or complexes. In terms of the intervals, which is the duration between different segments of an ECG, you have PR interval, then QRS duration. It's not interval, it's because it's the total width of the 3 waves or the complex itself. So QRS duration. Then you have an ST segment, which is the end of S and the start of the T wave, or end of QRS and then the start of T wave. And then you have a QT interval, we'll come to that later. Finally, an RR interval. And also you've got 2 segments, a PR segment, and then you have an ST segment. We will discuss them in the next slide. The main waves are P wave, which represents the sequential atrial depolarization of right and left atria. It's predominantly positive in 1, 2 and AVF leads and negative in AVR. Normal width is up to 3 small squares or 120 milliseconds. And also the height is approximately 2.5 millivolts, so less than 2.5 millivolts. Coming to QRS complexes are predominantly, they represent ventricular depolarization. The Q wave, if present, is the first downward deflection, the first upward deflection is R, and the second negative deflection after R is an S wave. Morphology depends upon the leads, and again the normal is up to 3 small squares or 120 milliseconds. Now the T wave is purely ventricular repolarization. In a lot of textbooks they mention that ST segment, which is isoelectric, ST segment and T waves both are actually part of the ventricular repolarization. And ST segment is where the actual mechanical contraction of the ventricles is taking place, but the repolarization phase has not occurred yet. So it's the plateau phase between the QRS and the T wave. However, the purists say that the T wave represents the ventricular repolarization. U wave, if present, is usually pathological, most predominant in hypokalemia and also sometimes in acute myocardial infarction. It's low amplitude. It occurs after T wave and before the onset of the next P wave. In terms of the intervals, PR interval reflects the time of onset of between the start of the P wave to the start of the QRS interval. The normal value is 3 to 5 small squares. Anything shorter than 3 means the PR interval is shortened, like Wolff-Parkinson-White syndrome. Anything above 5 small squares indicates conduction abnormalities, which could be due to the first degree heart block or second degree heart block, which we will discuss later. QRS duration indicates the ventricular depolarization time, and that is usually 3 to less than 3 small squares from the start of QRS wave, start of Q wave if possible to the end of S wave, or the QRS duration. That's the total QRS duration. QT interval reflects the ventricular depolarization and ST segment and ventricular repolarization as in the T wave. So it's actually ventricular activation time. This is the time when the ventricles are electrically active. So that is QT interval from the start of Q to the end of T wave. RR interval is a time interval between 2 consecutive R waves, and that is important for ventricular cycle. You can also calculate the PP interval, which is the atrial cycle. So if there is a dysynchrony between the PP waves and RR waves, that means there is a AV nodal block, and hence there is dysynchrony between the atria and ventriculars. Coming on to segments, this is important. So we had waves, then we have the complexes, and now we are talking about segments. So segments are the connecting points between 2 different complexes or 2 different segments of the ECG. So you have PR segment. Remember, we are not talking about the PR intervals. PR interval was from the start of P wave to the start of QRS. Here the PR segment is from the end of P wave to the start of QRS complex, and this reflects the AV nodal conduction delay, and it should be isoelectric. Similarly, ST segment, as the name suggests, it's at the end of S wave to the start of T wave. So it's the isoelectric line after the J point when the QRS becomes isoelectric to the start of T wave. Normal situation, it should be isoelectric, and any elevation of ST segment would imply either ST elevation MI or pericarditis or Brugada syndrome, and depression can also indicate ischemia or digoxin toxicity and some other reciprocal changes in acute MI. Then coming on to the TP segment, as the name suggests, it's from the end of T wave to the start of the next P wave, and this represents complete electrical quiescence. So this means there is electroneutrality in the electrical system of the heart, and it is used as a reference isoelectric baseline for the ST assessment. When there is tachycardia, then this ST segment, the TP segment becomes quite shortened because there is a reduced time interval between two consecutive heartbeats, so hence the shortening of the TP segment. As for the cardiac vector, we need to look at the hexaxial reference system. So there are three bipolar limb leads, which are 1, 2, and 3. And then we have unipolar leads, AVR, AVL, and AVF. Now looking at the bipolar limb leads, 1, 2, and 3. So lead 1 is, if you consider lead 1 as to the left, it is 0 degrees. So lead 2 is 60 degrees and lead 3 on the right side is 120. So these three are separated by 60 degrees each. In terms of the unipolar leads, the AVR, AVL, and AVF. So AVR sits at the right shoulder, which is minus 150. AVL sits at the left shoulder, and that is minus 30 degrees, while AVF is straight down ahead, which is 90 degrees. If you look at the difference between the unipolar leads and the limb leads, so there is a difference of 30 degrees. For example, AVL is minus 30 and lead 1 is 0, so that's a 30 degrees difference. Between leads 2 and AVF, again, we have 60 and 90 degrees, so that's a 30 degree. AVF and lead 3 is again between 90 degrees and 120, there is 30 degrees. And between lead 3 and AVR, again, it's you have plus 120 to minus 150, but that's a negative angle on the right side. So between them, between these 6 leads, they cover 360 degrees. So think of these 6, 1, 2, 3, AVR, AVL, and AVF. Think of these 6 as 6 different cameras looking at the heart from different directions. So basically, you are talking about the net electrical activity going through different leads in the heart, the different leads which are capturing the electrical activity of the heart from different direction. And the net electrical activity determines the cardiac vector, and that is usually 57 degrees. And in a rough estimate, you can think of it like a 60-degree angle towards the left, which is the yellow arrow reflecting here. Why is it important? Because electrical vector determines how the waveforms appear in different leads. So we will discuss in the subsequent slide the importance of the current traveling towards a lead or away from the lead or at a right angle to a lead. And this is the practical importance of the vector and the electrical current and the lead axis itself. So if you look at the first box on the top left side of the screen, whenever the electrical current, the vector, travels towards a particular lead, the deflection is predominantly positive. For example, if you look at lead 2, this usually the waves, the P waves, QRS, and all of those complexes are positive because they're traveling towards lead 2, and the cardiac vector, if it's normal, at 60 degrees. If the vector is away, if the current is flowing away from the lead, then it produces a predominantly negative deflection, which predominantly the lead AVR, because it's exactly opposite the cardiac vector towards the right shoulder, so all the complexes appear negative. On the other hand, if the net direction of the current is perpendicular to the lead, then it produces either isoelectric or equipolar, equidistant from the isoelectric line, so equal biphasic as positive and negative deflection, and this is important. In the previous slide in the vector, I forgot to mention actually that the normal cardiac vector is between minus 30 to plus 90. So the range is, this is the range, but the exact vector is, in a normal situation, is plus 60 degrees or plus 57. But the range was reflected in the green arrow diagram, the green diagram, which is minus 30 to plus 90 degrees. Anything Beyond this will be axis deviation or vector deviation, which we can discuss later in our discussion slides. Next, let us understand the cardiac vector and the relationship of different waveforms and different leads. So we have 10 electrical electrodes, 6 chest electrodes and 4 limb electrodes producing a 12 lead ECG. So that's one concept to understand. Electrodes and leads are not the same thing. Secondly, we have the cardiac vector diagram as I've shown you before. The green is the normal zone. So minus 30 to plus 90 is the range. 60 degrees is a normal cardiac vector or cardiac axis. If you look at the predominant placement of the electrodes, the chest electrodes especially, V1 sits on the right side in the fourth intercostal space on the right side of the sternum. V2 sits on the left side, fourth intercostal space. Then look at the V4. V4, 5 and 6, they sit in the fifth intercostal space in the mid-clavicular, anterior axillary and mid-axillary line, while V3 sits between V2 and V4. So this is the important one. So fourth, and then fifth intercostal space, and then midway between fourth and fifth. So V1, V2, V4, V5, V6, and V3 sits in the middle. Now, if you look at the limb leads, 2, 3, and AVF, because they are facing towards the vector, the QRS complex is predominantly positive in these leads. Unlike this, lead 1 is on the left side, so it is positive, but the voltage is less strongly positive. AVL is on the left side, so it can be sort of neutral or slightly negative. AVR is predominantly right shoulder, so it is definitely negative. If you look at from V1 to V6, the chest leads, the V1 sits on the right side, that's why the QRS complex is predominantly negative. V2 slightly positive, but V3, 4 and 5, because they're facing the vector, so QRS are positive. Same as V6, which is positive, but because it's farther away, the voltage of the complex is less positive as compared to other leads. This next is a very important slide actually. I think it's one of my most favorite in this presentation. It's to look at the 12 lead ECG territories, different territories, and you can see I previously discussed about the lead placement, the electrode placement to be honest. So V1 to V6 are the leads, and 1, 2, 3 1 AVL, 2, 3 F and AVR are the limb leads. So the chest and limb leads together. So 12 lead ECG. So the red one in the middle shows 2, 3 and AVF, which is reflecting the inferior territory of the cardiac ECG. V1 and V2, the two topmost chest leads are representing septal territory. So V1 and V2 for if there is a problem with like a septal myocardial infarction, then you would have changes in V1 to V2. Anterior territory is reflected in V3 and V4. So V3 and 4 we discussed. So V1 and V2 fourth intercostal space, right and left of the sternum. V4, 5 and 6 is fifth intercostal space, mid-clavicular, anterior axillary and mid-axillary line, and V3 is here in the middle. So V3 and V4 reflect the anterior territory. Now V1 AVL and V5 and V6, they represent the lateral territory. So these are the important leads and the territories to remember. Now this is the real crunch and business part of the presentation, the top 10-step systematic approach to read an ECG. As a comparison, I put down the standard normal sinus rhythm ECG with waves, intervals and complexes. Your 10-step approach includes the 3 steps, which are rate, rhythm and axis. So first of all, we need to calculate the rate, look at the rhythm and calculate the axis, or at least know whether the axis is normal or deviated. So these are the 3 steps. Then we predominantly come towards the waves and the intervals and complexes in a sequence of how they appear on the ECG. So if you look at P followed by PR, QRS, STT, etc., etc. So our AG dove, the Argentum dove, is giving us the right balance, a systematic approach of this particular ECG interpretation. So first of all, rate, rhythm, then number 2 is rhythm, number 3 is axis. Then we look at the P wave. We'll come to that in each step at a time. Then the PR interval, which is the start of P to the start of QRS complex. Then we have the QRS complex itself, followed by the ST segment and the T wave. And I'll come to that. We can take ST segment and T wave together because their etiologies, pathologies are usually linked. Finally, the QT interval from the start of the QRS to the end of the T wave, the ventricular activation time that we were discussing. And my last one of the most important tips, the step 10, is the comparison with an old ECG trace if available. That's a real pro tip, because you cannot comment on the findings, especially in a patient who is not symptomatic, by just looking at the ECG, and you have to compare with the old ECG to see whether it's a fixed change or dynamic change or it's a new change. So let us start with the first of the 10 steps in the next slide. Step number 1, calculating the rate on an ECG. Predominantly we are talking about electrical equivalent of the resting heart rate or resting heartbeat per minute. So this usually reflects the ventricular rate or the R rate. So we will look at the next slide on how to calculate the rate on an ECG. For rate calculation, there are two methods. Depends whether the rhythm is regular or irregular. So in this situation, when the rhythm is regular, we know that the speed of the paper is 25 millimeters per second. We looked at all the the numbers and the values of horizontal and vertical axis. So in this situation, you need to find out the rhythm strip, which is rhythm strip 2 at the bottom here. Find out an R wave which lands pretty much exactly on a large square. Then count the large squares next to the R wave. So if the next QRS complex or the R wave falls to the next square, it means the rate is 300, because it's 300 per divided by 1. And if it falls on the second one, it's 300 divided by 2, which is 150 rate. And then similarly, if it's the third one, it's divided by 3, which is 100. Fourth one will be divided by 4, which will be 75. In this situation, it falls between 100 and 75, so the rate is around 80-81 beats per minute. For reference, any rate less than 60 is bradycardia, the normal is 60 to 100, and anything above 100 is tachycardia. Similarly, if the heart rate is abnormal, irregular, then in that situation, you need to find a rhythm strip and find the appropriate differential of the number of large squares. As we said, 15 large squares, so 5 large squares equal 1 second, so 15 would equal 3 seconds. So if you can either find 15 large squares, which is 3 seconds, you need to multiply the number of R QRS complexes in that interval by 20. If you can find 30 large squares, which will equal 6 seconds, then you can multiply by 10. Like in this situation, in an example, if you look at the orange arrows, so the starting time is 0, and then from there you've got 5, 10, 15, 20, 25, and 30. So you've got 30 large squares, which equal to 6 seconds. So the number of QRS complexes here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 10 large squares, 10 QRS complexes in 6 seconds, multiplied by 6, the heart rate, multiplied by 10, sorry, the heart rate will be roughly 100 beats per minute. So this is how you calculate in the rhythms when the rhythm is irregular, for example, atrial fibrillation. Step number 2 is to look at the rhythm. So then we said step number 2, rhythm. So what is a normal sinus rhythm? In a normal sinus rhythm, 2 conditions must be met. Number 1, that the P waves are of sinus origin. So P waves are present and they are of sinus origin. To confirm the presence of P wave, you need to look at the morphology. So this means they are originating in the SA node, the pacemaker, the natural pacemaker of the heart. So the normal morphology, as we discussed before, the width has to be less than 3 small squares and the height has to be less than 2.5 small squares. So the width is actually less than 0.12 seconds. So each small square is 0.04. So 3 will be 0.12 seconds. And the axis should be upright, so which means in lead 2, we were discussing before, so lead 2 is facing downwards. So the cardiac vector or the axis is facing it, so that it means it should be upright in lead 2 and negative in AVR. So that is the sinus origin. Now, once the P wave is present, it doesn't mean that it's a normal sinus rhythm, because then the second condition has to be met, which means that every P wave is followed by a QRS complex. And hence the relation should be 1-to-1 relationship between atrial depolarization and ventricular depolarization, which means the electrical impulse is being conducted from the atria through AV node to the ventricles. And this impulse means that this is the sinus origin. So if the P waves are present, then it's a normal sinus rhythm provided the second condition is met. If P waves are absent, then consider either atrial fibrillation or junctional rhythm. And if it's present but there's a variable degree of the QRS complexes, it can mean that it can be a block. We will discuss down the line. But these are the two predominant conditions. And remember our AG dove from the MedEd quartet. So those of you who have not met before, so it's a techie beetle, bready turtle, gold or AU beetle, and my nice argentum dove, which means the balance. So this argentum dove is reminding us of the balance of the atrial and ventricular synchrony and the normal sinus rhythm. So on this slide, this is the classic example of a normal sinus rhythm. If you look at the lead 2 at the bottom of the ECG, which is from the origin, the source is from the Life in the Fast Lane website with thanks and acknowledgement. So there is a P wave, which is a normal duration and morphology, and it's followed by a QRS. So every P wave is followed by a QRS complex, which means it's a normal sinus rhythm ECG. Our step number 3 is to look at the axis, and please refer to our discussion on the cardiac vector. So axis and vector is interchangeable for ECG purposes, so we will come to that. Now let's look at the calculation of or assessing the cardiac axis. There are many different detailed methods, but the one that I will be referring to is what is called the thumb rule. So this is the standard application. Look at the leads 1 and 2. So your thumb, your left hand thumb, the left thumb is actually representing lead 1, while the right hand thumb reflects lead 2. So you need to just point the thumb towards the positive QRS reflection. So, and that whichever thumb stays upright shows that particular hand's axis. If both are upright, it's a normal axis. If lead 1 is positive, which is left thumb, but lead 2 is negative, which is right hand thumb, it's left axis deviation. And if it's lead 2 is positive and 1 is negative, then the thumb which is pointing upwards is the axis. We'll discuss in just the following 2 slides also. So let's look at the normal axis. As we said before, lead 1 in the ECG reflects the left thumb, lead 2 reflects the right thumb. So if both lead 1 and lead 2 are upright, predominantly upright, more than 50% of the voltage is above the isoelectric line, it's normal axis, which is, we discussed before in the cardiac vector, if you remember, from minus 30 to plus 90 degrees. So this is the range, and the standard is, the median is 57 or 60 degrees for you to remember easily. If you look at the inset in the diagram, the orange part, which is a circle in the blue oval, this is the minus 30 to 60. So this is the normal cardiac axis. Okay. So if both thumbs are upright, that's a normal cardiac axis. Coming to the right axis deviation, if lead V1, which is the left thumb, is downward, it's deflected downwards, and lead 2 is upright, that shows the right axis deviation because our right hand thumb is upright. So this is a crude way of doing it, but a very simple and easy bedside method of doing it for medical students, internal medicine, or any medical trainees or residents. If you look at the inset, the yellow part shows the right axis deviation. Okay, so beyond plus 90 degrees. So minus 30 to 60, 90 was normal. Beyond plus 90 degrees is the right axis deviation. What are the common causes of right axis deviation? Is anything which is affecting the right side of the heart. For example, right ventricular hypertrophy. So predominantly you've got bigger muscle bulk of the right ventricle, which contributes now to the higher voltage. So hence the cardiac axis is going to be shifted from this side more towards the right side. Same is right bundle branch block. If the right bundle branch is not depolarizing, the left bundle branch will have to sequentially depolarize the right side of the heart, leading to the deviation of the vector or the axis to the right. Same is left posterior fascicular block. So again, similar mechanism, posterior fascicle is blocked, the anterior one will depolarize. So again, the direction of the vector will be deviated to the right. Same applies to pulmonary embolism and also lateral wall myocardial infarction. One pro tip, remember, is the dextrocardia. If the whole heart is deviated to the right side, the cardiac vector will be definitely abnormal. So this is an important exam tip to remember. Similarly, coming to the thumb rule for the left axis deviation. So if lead 1 is upright, which is the left thumb, and lead 2 is downward, which is the right thumb. So this means that, so which hand gives the thumbs up? So left hand is giving the thumbs up, hence it's a left axis deviation, which is reflected in the green part in the inset diagram right next to my talking head. If you can see, it's also in the orange oval shape. So again, here you think about the causes which can lead to so exactly opposite to what the right bundle branch block was, the right axis deviation were. So here, over there, we had the right ventricular hypertrophy. So here it will be the left ventricular hypertrophy. So if the left ventricle has a larger mass, it will contribute to the higher voltage and hence the left axis deviation. So instead of minus 30 to plus 90, you're not now talking about minus 30 beyond, minus 30 to minus 60, minus 90, etc. So that's the left axis deviation. Other causes include left bundle branch block. So again, if the left bundle branch is not depolarizing, the right one has to depolarize from the right to the left. So that will lead to the shift in deviation. Again, our bready turtle can remind you of the slow depolarization and hence the longer time it takes for the depolarization, and hence the normal synchrony is affected. Other causes, inferior MI, unlike the lateral MI over there. So again, if it's inferior wall MI, the dynamics and the electrical depolarization is affected and hence the vector is shifted to the left. Wolff-Parkinsonian-White syndrome, again due to the accessory right sided pathway. So these are the common causes of left axis deviation. Step number 4, let's look at the P wave. So what does a P wave tell us? We know that P wave means atrial depolarization, sequential atrial depolarization of the right and left atria. For it to be of a sinus node origin, certain conditions have to be met. So it has to be upright in 1-2 and AVF and inverted in AVR, and it's biphasic in V1, which is normal. The duration has to be less than 3 small squares in width, and the height has to be less than 2.5 millimeters. So this is the normal sinus node origin P wave. When do we say that it's a normal sinus rhythm? When the P wave, which is from sinus origin, is succeeded by a QRS complex. So before QRS, there is always a P wave, and it is upright in lead 2, negative in AVR, consistent with P wave morphology or sinus node morphology, as I said in the first column. And the PR interval is less than 3 to 5 small squares, which means less than 200 milliseconds, and between 3 to 5 small squares. Anything less than 3, it is shorter PR. And the heart rate is between 60 and 100, which means it's a normal sinus rhythm. So basically, on the next slide, we will go through some of the P wave abnormalities. We are looking for P mitrale, P pulmonale, inverted P wave or absent P wave. So we will come to that in a while. Let's look at a systematic approach to the P waves. These slides which I have prepared have taken me the most time in this presentation, and I love this particular flow chart actually. So please pay attention. First of all, we need to ask yourself on the ECG, are the P waves present, yes or no? If the answer to the presence of P waves is yes, then we go to the right side of the algorithm, which then we need to look at the P wave morphology as the next step. So if and when our answer to the presence of P wave was yes, then the next question is, are the P waves of normal morphology? And we discussed in the previous slides, if the morphology is normal, then it's most likely a sinus rhythm origin or normal sinus origin. We cannot still say that it's sinus rhythm purely on the basis of P wave, because QRS is part of the sinus rhythm. Anyways, the origin of the P wave is in sinus. If the morphology is not normal, then we come to the next part of the algorithm. And if the answer to the P wave morphology is no, that means it's not a normal morphology, it's an abnormal morphology. Then the next question is it of sinus origin? Remember, it can still originate in the SA node, the sinus node, but the morphology may be abnormal. And if the sinus node origin means yes, then it means it's a sinus origin with abnormal morphology. So why is the shape different? Because it could be P pulmonale, which means a tall P wave, which is more than 2.5 millimeters height in leads 2, 3 and AVF, or it could be P mitrale, which means it's a bifid P wave, like an M shape, and it's more than 3 small squares wide, more than 0.12 seconds in leads 2, and also it's biphasic in lead V1. So it's an abnormal morphology, but of sinus origin. And if the question to our the previous step was that is it of sinus origin, and if it is no, then it really means the origin of the P wave is elsewhere, which could be anywhere in the atrium or close to the junction with the AV node. So again, it could be a retrograde, which means it could be a negative deflection of P wave. It could be an ectopic P wave. And in this situation, usually it's inverted in leads 2 or 3 in AVF because it goes against the cardiac axis or vector, and retrograde depolarization of the atria, hence it's a negative amplitude. And then let's say for our first question, are P waves present? We headed towards the yes side. If the answer to that is no, then the next question is, do we have fibrillatory or F waves present in the baseline of ECG? The two options could be yes and no. And if the fibrillatory or F waves are present in the baseline, then it's likely atrial fibrillation, which is irregular, and the F waves can be 350 to 600 beats per minute, but not all of them will be transmitted. And also atria is not producing any meaningful contraction, so that's why it's a fast atrial fibrillation with rapid ventricular response, but the ventricular rate is usually not as high as 350 to 600. It will be higher, but not all of them will contribute towards a ventricular depolarization and contraction. And if the answer to the presence of P wave is no, then, and if the fibrillatory waves are also absent, so none of the fibrillatory waves are present, then it could be atrial flutter, which has a sawtooth appearance. By the way, we'll come to all the ECGs in the next slides, but this is just a flow chart. And the regular sawtooth appearance of the baseline means that the F waves, which could be at the rate of 300 per minute, but if it depends upon the degree of the block, so if it's 2 to 1 block, then you will have a ventricular rate of nearly 150 beats per minute. And one final tip, that absence of P waves doesn't occur only in atrial fibrillation or atrial flutter, but there could be other reasons for absence of P waves, like junctional rhythm, as we discussed before. Sometimes they may be totally absent rather than negative or inverted. It could also be hyperkalemia or cardiac pacing. So these are some of the other reasons for absence of P waves. So absence of P waves, atrial fibrillation, just a quick recap. Usually the heart rate the ventricular rate is usually slow, but the atrial can be 350 to 600 as you said before, but the AV node itself filters a lot of these chaotic irregular waves, and eventually only some of them are transmitted, which leads to irregular heartbeat. So that's why the rhythm is irregular. The P wave is clearly absent, and there is only fibrillatory baseline undulation. PR interval cannot be determined because we do not have a P wave to start with. And the QRS interval is usually less than 0.12, which means some of the waves are transmitted and eventually that leads to ventricular depolarization. So these are the differences between normal sinus rhythm and AF. Chad's to West scoring is done to look at the calculation, look at the risk for embolic stroke. And in males, if the score is 2 and above, then you need anticoagulation, and in females, if it's 3 and above. Rate control is done with usually cardioselective beta blockers or verapamil. The target rate is usually less than 110, and rhythm control can be done with either DC cardioversion if the onset of atrial fibrillation is confirmed to be less than 3 days, or once the left atrial appendage or left atrial thrombus is excluded using transthoracic or transesophageal echocardiography. Otherwise, other than DC cardioversion, pharmacological cardioversion can also be achieved through the use of amiodarone or radiofrequency ablation down the line if it's a recurrent AF or symptomatic. Remember, if it's AF with Wolff-Parkinsonian-White syndrome, then never use drugs which delay the AV nodal transmission, because that will accelerate the transmission through accessory pathway, and it can degenerate the malignant arrhythmias. So in such situations, flecainide or DC shock is preferred. So this is an important exam tip for MRCP and USMLE exams. Looking at a classic example, so this is an ECG trace from life in the fast lane. You can see the baseline undulation, fibrillatory waves or F waves, and the RR intervals are variable, and there are no obvious P waves and a narrow QRS complex. So I've used our Techie beetle for this particular reason. Techie is from tachycardia red beetle or burgundy beetle or Techie, to signify the importance of fast atrial fibrillation and the rapid ventricular response. Next is a classic example of atrial flutter with a fixed block. So why is it atrial flutter? Because unlike atrial fibrillation, we can see the sawtooth appearance of the baseline, especially in the inferior leads, and there is a constant conduction ratio. So if you look at the arrows on this ECG, so because you've got the third wave, so every third wave is being conducted, so it's a 3:1 block, which means the ventricular rate is 1/3 of the atrial rate. So this is a classic example. Once again, rate control and consider DC cardioversion or ablation as the case may be. In terms of the left atrial enlargement in P mitrale, what happens with the left atrial enlargement, because both right and left atria contribute to the atrial depolarization. So whenever there is left atrial enlargement, that leads to increased mass of the left atrium. So that's why it produces a separate hump or an M-shaped due to its own weight and volume of the depolarization, should we say. And the voltage contribution because of the left atrium significantly changes the shape. So that's why there is a notched or a bifid wave from V and in lead 2, while in V1 there will be a deep negative terminal. We'll show it in the next slide as well. And this is due to the mitral valve disease. It can be hypertensive, it can be aortic valve disease, hypertrophic cardiomyopathy, atrial septal defect, anything which leads to the mitral, the left atrial enlargement. It can be either a mitral valve or the outflow tract problem ahead of the mitral valve, which could be the ventricle, the aortic valve, which ultimately leads to enlargement of the left atrium, not necessarily due to the mitral valve itself. So this is a classic example. If you look at the normal in leads 2 and V1, in leads 2 it's upright. V1 is a small bifid deflection in V1 in a normal situation. So the left atrial enlargement, LAE, the third row, gray row, in lead 2 you will have a bifid P wave, M-shaped, and in lead V1 there will be a significantly down slope of the second deflection. So this is the P mitrale. If you see the real-time ECG, lead 2 at the top, lead V1. Lead 2 at the top is M-shaped, and lead V1 will give a negative deflection. In contrast, the right atrial enlargement, which is reflecting obviously the pulmonary valve, so it will be P pulmonale. So the increased amplitude of this particular wave will be higher. So it will be more than 2.5 small squares wide, tall or high. And that's the height of the voltage of the height will be affected. So it can be peaked and pointed as well. In terms of pathophysiology, we discussed that the right atrial depolarization, it depolarizes first as compared to the left. So this leads to significant initial component of the P wave. So in right atrial enlargement, it will lead to the increased amplitude of the already known P wave in both lead 2 and V1. The usual causes for right atrial enlargement are either the pulmonary valve itself or anything to do with the right outflow tract. So this could be pulmonary hypertension, COPD, col pulmonale, pulmonary stenosis, tricuspid stenosis, congenital heart disease, any condition which affects the right side of the heart. This is a classic example, a beautiful ECG to describe this phenomenon. If you look at lead 2, the amplitude of P wave, it is so tall that it's almost 3/4 or almost 80% of the height of the R wave, and also it's very sharp and pointed in lead 2. So this is characteristic for P pulmonale or right atrial enlargement. So step number 5 out of the 10-step interpretation of ECG is the PR interval. Okay, so let's look at the short PR interval. If it's too short, like less than 3 small squares, the classic example is Wolff-Parkinsonian White syndrome, which is a pre-excitation. So what does it mean? There is an accessory pathway along with the standard SNO to AV nodal pathway, and due to that accessory pathway, there is an extra electrical connection between atria and ventricles which bypasses the AV node entirely. This is called Wolff-Parkinsonian White syndrome. On the ECG, there are 3 classic features: a shortened PR interval, a slurred upstroke at the start of QRS, which is called the delta wave, and that occurs because of the rapid conduction through the accessory pathway. And the third feature is a wide QRS complex, because the ventricular excitation starts earlier than the normal pathway, which goes through the AV node and then his Purkinje system. What is the clinical relevance? We discussed in the previous slide that if a patient with WPW syndrome develops atrial fibrillation, then we should not give AV nodal delay drugs like the beta blockers and calcium channel blockers, because they will block the normal AV nodal conduction and the accessory pathway is still going to work. and that can lead to potential malignant arrhythmias like ventricular fibrillation. That's why our tachy beetle, the burgundy, shows you the risk. So we need to remember that, and we need to maintain a balance, a proper balance of patient safety rather than AV nodal delaying drugs. And the definitive treatment of this particular condition is the radiofrequency catheter ablation of this accessory pathway so that the normal physiological balance is maintained, which is signified by our AG or Argentum dove. And this is a classical ECG of WPW pre-excitation. As you can see, a shortened PR interval, then there is an upstroke or a delta wave, predominantly very clearly visible in leads 3 and AVF, and even in lead 2, 2, 3 and AVF. And also the QRS is prolonged because of this particular reason. There is an earlier pre-excitation and earlier electrical conduction to the ventricles. On the other hand, if there is a prolonged PR interval, then we would be considering atrioventricular blocks, which is a spectrum of a conduction failure. So let's look at it. AV block is not a single diagnosis, remember. It could be from a benign etiology like a first degree block to the complete third degree heart block, which is a medical emergency and will necessitate an immediate life-saving intervention. First degree block, which is usually, so we remember, if you remember, we said the normal PR interval is 3 to 5 small squares. So if there is a prolonged PR interval, more than 5 small squares, but it's fixed in all the leads, and that is, it's usually asymptomatic, and it's usually considered as first degree heart block. Normally, in the absence of any symptoms, does not need any treatment unless there is a correctable cause, and it's usually benign and just needs monitoring and serial ECGs. Previous ECG comparison, which is my tip number 10, is one of the best things to see. Second degree block, it's an intermittent block. So again, it can be Mobitz type 1 or type 2. In Mobitz type 1, there is a sequential prolongation of the PR interval. If you look at the diagram in the middle, so the PR interval is narrow, is relatively normal in the first complex. It gets prolonged in the second, further prolonged in the third. Eventually, it is so prolonged that it fails to be conducted through AV node. So this is a progressive prolongation of PR interval until there is a dropped beat. So that is Mobitz type 1, usually benign, doesn't lead to any significant problems. However, Mobitz type 2 is the more concerning one because there is a fixed PR interval without any successive prolongation, and all of a sudden there is a non-conducted P wave, and this can lead to palpitations and pre-syncopal symptoms, and it has a high risk of getting degenerated into third degree heart block or a complete heart block. That's why it usually requires urgent pacing or a definitive intervention. On the other hand, the third degree heart block or a complete heart block is where there is complete dyssynchrony between atrial activity and ventricular electrical activity. So you will have a separate PP interval and a separate RR interval, and there is no correlation between the P and QRS. And also one other important aspect is that the QRS, because it's not normal sinoatrial nodal conduction, so the QRS will be wide interval. So an ectopic focus below the AV node will take over, and that leads to slower conduction, which leads to prolonged QRS. So that's an important part to consider. And usually it needs urgent either atropine or pacing. Again, atropine may have a limitation, but it can buy some time. A, B, C, D, E stabilization, atropine, on-call cardiologists have to be on board. Transvenous temporary pacing may be a bridge towards permanent pacing, especially if it is out of hours or if the local facilities are not available. So a classic example of first degree AV block. In this case, you can see the PR interval is nearly 8 small squares, greater than 5. That's why and there is no drop beat. And it's a constant PR interval which is prolonged in all the leads. Again, review the medications, check thyroid function. That usually leads to sinus bradycardia rather than first degree heart block. Check all the electrolytes. In this situation, our brady turtle, the slow turtle, bradycardia, the brady turtle will give us a clue towards a first degree heart block. So second degree heart block or Mobitz type 1, this is progressive. If you pay attention to the rhythm strip, the lead number 2 at the bottom, there is progressive prolongation of the PR interval from leads 1, 2, 3 and lead 4, and finally the complexes 1, 2, 3 and 4, and the complex number 5 it fails to conduct. So that is the failed conduction. So that is first degree Bouvet's AV block. And again, you need to look at the underlying risk factors, any previous ECG for comparison. Right coronary artery inferior ischemia can be one of the risk factors. Mobitz type 2, intermittent dropped QRS with constant PR interval. So if you look at the rhythm strip 2 at the bottom, so first, second, third, fourth QRS complexes are normal, and the PR interval also appears normal. However, there is a failed conduction after the fourth interval. Then we have 5 intervals, then a failed conduction. So again, there is no pattern. So this is a sudden drop beat which is unexpected, non-conducted, and yes, it has a danger of going into complete heart block, which can eventually lead to serious consequences. And hence the Brady turtle shows us the failure of conduction or the slow conduction. However, the techie beetle signifies the importance of the risk of arrhythmias and sudden cardiac death. So that's why it's really important for early intervention. And third degree complete heart block is signified by our classic Brady turtle here in this situation. As you can see, it's a very, very slow conduction. There is no association of the P waves and the QRS complexes. There is complete dyssynchrony between the P wave rate and the QRS complex rate. So this is a complete heart block, and it signifies, and also you can see the QRS interval, which is quite prolonged, which signifies the origin of the QRS waves below the bundle of His. And external pacing with a view for permanent pacemaker implantation is a definitive treatment in such situation. Okay, so the next step, on step number 6, is the QRS complex. So before we move on to the bundle branch blocks themselves, let's look at what does a prolonged QRS interval mean. So the normal cardiac conduction includes SA node, AV node, and finally from AV node through the bundle of His to the left and right bundle branch blocks, which both fire simultaneously, enhance the final depolarization towards the Purkinje network and resulting in a narrow QRS. So synchronized biventricular depolarization resulting in a QRS interval of less than 120 milliseconds or 3 small squares. Now what happens in a bundle branch block, as you can see in the middle column, let's say there is a right bundle branch block and now the left bundle branch is only working. So eventually once the left ventricle is depolarized, now the left ventricular myocardium is going to depolarize the right ventricular myocardium. So it's going to be myocardial to myocardial depolarization rather than the fast Purkinje system depolarization. So it's a cell-to-cell spread which is slower. So that leads to widening of the QRS interval. Again, it can be complete or a partial bundle branch block. Incomplete, the duration will be more than 3 small squares or more than 120 milliseconds. In incomplete, it can be less than this interval, 110 to 120 milliseconds, but the pattern will be different. So that's the main difference. So this is the difference between a normal conduction and a bundle branch block conduction. So let's look at each bundle branch block in isolation. Left bundle branch block. In a normal situation, both bundle branches are working normally. In the inset and the midlife, you see if the left bundle branch block is not working. So the first depolarization will happen due to the right bundle branch block to the right ventricle. Then the cell-to-cell transmission from the right ventricle will depolarize the cells in the left ventricle, and that will lead to the delayed depolarization of the left ventricle. What it does is that in V1, first of all, the QRS is going to be prolonged in a complete bundle branch block more than 3 small squares, so more than 120 milliseconds. So that's the first criteria. The second is you will have a different pattern in the chest leads V1 to V3 and in lateral leads 1, AVL, V5 and V6. Now, if you look at V1 to, we discussed before in the cardiac axis or vector. So V1 and V2 are on this side in the right intercostal space, right fourth intercostal space. So V1 is here, V2 is here in the left side. So because they are away from the vector and the cardiac axis, so they will be predominantly negative. Now in this situation, you will have either the QS pattern or a small r and d big S, so RS pattern in V1 to V3, which means there is a tiny R wave but a deeper S wave. That is due to the left ventricular depolarization which takes place from the right ventricle, from the right ventricular conduction, right to left. And the other leads, which is the lateral leads 1, AVL and V5, V6, so they will have a notched second R wave, and that leads to an M type of a pattern. So this, the mnemonic, and also you will have a discordant ST and T wave changes. So this is an example of left bundle branch block pattern. The mnemonic is William, so W in V1 and M pattern in V6 as we discussed before. So predominantly deep and dominant S wave in lead V1, which leads to the characteristic W pattern, and then a bifid notch, a broad notched M pattern in R wave due to the second notched R in V6. Similarly, coming to the right bundle branch block pattern, again the right bundle branch is blocked, so the left bundle branch will lead to depolarization of the left ventricle first, and eventually it will be cell-to-cell transmission from the left to the right side. Hence, when the vector is facing towards the V1, it will lead to a second upward or upslurred second R dash. R will be the first one for the left ventricle. The second predominant R wave will be for the right ventricular depolarization. So that leads to an M type of a pattern with deep S wave and two waves, two R waves on either side of the deep S wave. So that leads to an M pattern in V1. Same is in V6, which is away from the vector this time, and that leads to downward deeper deflection after the R wave. So that's a slurred S wave that leads to a W pattern like a marrow. So M in V1, W in V6, that leads to the marrow mnemonic, MARR. So RR stands for the right bundle branch block. So similar to the left bundle branch, here we have the right bundle branch block pattern. Remember the mnemonic marrow, so M pattern, which is predominantly in lead V1, and W pattern in lead V6. So let's just quickly look at the ST and T wave, ST segment and T wave together, because a lot of these pathologies are linked together. Left ventricular hypertrophy with strain pattern, with or without strain. So there are voltage criteria, many different criteria, but the voltage criteria for left ventricular hypertrophy, for those you need to look at the tallest R wave in V5 or V6 and the deepest S wave in V2 and V3, predominantly usually in V2. So if you look at this particular ECG, the tallest R in V6 plus the deepest S in V2, if it's more than 35 millimeters, in some criteria they say more than 37, but if it's more than 35 millimeter, like more than 7 large squares, that would indicate left ventricular hypertrophy, as in this case. Now, when do we have a strain pattern? Strain means there is a myocardial ischemia, relative myocardial ischemia, or strain due to the left ventricular hypertrophy due to excessive muscle bulk. Then you have ST depression and T inversions in the lateral leads, 1 AVL, V5 and V6, or ST depressions in V1 to V3. And also sometimes prominent U waves occur in V1 to V3, and there is left axis deviation. So let's look at the ECG territories and the relevant coronary arteries for some of the changes in acute MI. On the right side, as you can see the inside of the main diagram, the inferior walls are indicated by the leads 2, 3 and AVF, and that's usually right coronary artery in about 80% of the cases, and also possible left circumflex artery. Anterior MI or anterior changes are indicated by leads V1 to V4 on the ECG, and that's usually due to proximal left anterior descending. Lateral, we know 1 AVL, V5 and V6, and the blood supply usually is from the left circumflex and diagonal branch. In terms of posterior MI, the posterior wall, that's usually the posterior leads, V7, V8, V9. For that, you need special placement rather than the normal anterior lead placement, because you will have reciprocal changes anteriorly. And similarly, for the right ventricular infarction, you need the same V3 and V4, but now the right-sided placed leads to be able to pick them up. So these are the different territories, and it's really important to understand the logic, rationale, and also the distribution of these for easy interpretation. For ST elevation MI, the voltage criteria are at least 1 millimeter ST elevation in the limb leads, and at least 2 or more millimeters of ST elevation in the chest leads. And again, the changes have to be in at least 2 contiguous territory leads. So in this example, you have more than, easily more than 1 millimeter ST elevation leads 2, 3, and AVF, which is inferior territory. And there are reciprocal changes occurring in the lateral leads. So lead 1 and AVL, you can see there are reciprocal ST depression and T inversions. So this is indicative of acute inferior ST elevation myocardial infarction. One of the first things would be STEMI protocol activation, which would have already been done by now by the paramedics if the patient has been arriving pre-hospital to the regional center. Similarly, this next ECG, you have clear ST elevations in the anterior leads, precordial leads, starting from V1, but predominantly in V2, V3, and V4. Characteristic finding, and it's and also you can see some changes in V5 and 1, lead 1 as well. So 1 AVL, but may not be the full criteria for the lateral involvement. And also V6, so you don't have the full contiguous involvement of the lateral wall. So however, V1 to V4, there is clear ST elevation MI in the anterior territory, which indicates LED occlusion. And once again, it's really critical because of the impending left ventricular failure. So emergency urgent primary PCI will clearly be indicated in this case. Now this is a really interesting and important one, posterior MI. So if you look at the ECG, there is clear ST elevation in the posteriorly placed leads deliberately, the V7 and V8, which were originally V1 and V2. And the clue to that is, if you look at the V3, there is a clear ST depression, which was originally the case in V1 and V2 as well. So V1, V2, and V3 were showing significant ST depressions, which were the mirror image, the reciprocal image of the posterior wall. So the moment you place the leads, the V7 and V8 on the posterior wall, they pick up the correct electrical pattern, which is an ST elevation indicative of posterior wall MI. So do not often miss this posterior wall changes, reciprocal changes on mirror image changes as just ischemia. So if in doubt, do the posterior leads V7, V8, V9, and that would give you the diagnostic clue. Next, we will just quickly look at the T-wave morphology in isolation. The two main pathologies or problems with T-waves can be acute tall tented T-waves, indicative of hyperkalemia, which can also lead to, eventually, if it becomes severe, it can lead to the flattening of the P wave and PR prolongation and all the subsequent widening of the QRS complexes. So these are the sequential changes. And also hypokalemia, in which case you will have ST depression with T inversion plus a positive upward deflection, a small upward deflection called a U wave, which we discussed previously. So if any of these cases, we need to, especially in hyperkalemia, we need to be very careful because cardiac membrane stabilization is the first priority. This is one of the most startling ECGs for acute hyperkalemia, as you can see, which is definitely called silent killer because it doesn't lead to any symptoms on its own unless it's associated with some other secondary pathology. In this situation, you can see the characteristic tall tented T waves, absolutely pulled like somebody is pulling them up like the tent, the top of the tent. And also you can see some broadening of the QRS complexes as well. So this is a life-threatening emergency, and our tachybeetle, the Burgundy, would indicate the same. And we need to stabilize the cardiac membrane. So our AG, Argentum Dove, would suggest, stabilization, maintaining the homeostasis and cardiac membrane protection for the patient. So that's why calcium chloride or calcium gluconate, whichever is local protocol, you need to institute it as soon as possible. And then obviously the potassium shifting mechanisms and removal mechanisms from the body. I'm going to touch on acute hyperkalemia in one of my separate videos in detail. So the next abnormality is the presence of a U wave that is usually indicative of hypokalemia. As we discussed previously, there is an ST depression and then or a flattening of the T waves plus prominent U waves which occur after the T wave. So please do not confuse the U waves with the P wave. So U wave will appear after T wave and before the start of the next P wave. So it's predominantly, you can see them in more in the rhythm strip. So one of the key priorities would be potassium replacement, checking the magnesium, because hypomagnesemia can lead to hypokalemia, and both of them can coexist, and especially both of them can also lead to prolonged QT interval, QTC. But you need to be careful with digoxin patients. Sometimes patients with digoxin can also have similar, reverse tick sign and all those changes. So just be careful with some of those patients as well. Okay, coming to the second last step, step number 9 is a QT interval, predominantly the corrected QT interval. Okay, so QT interval, as we had discussed before, so what exactly is QT interval? If you remember, we discussed previously, the QT interval is actually the ventricular activation time. This includes both the QRS complex and the ST segment and the T wave. So it starts from the onset of from the start of the QRS complex to the end of the T wave, the clear end of the T wave. The best leads to check QT interval is the rhythm leads 2 or V5, because they're facing towards the cardiac vector, and you have to establish the start of the QRS to the end of the T wave. And the longest QT across all leads, that has to be checked for clarity. You can use Bezd's formula. Luckily, these days, most of the automatic ECG machines have a QT and a QT corrected, so you don't have to correct yourself. But if you have to, and if there is no option, like in some of the countries, they just have a long rhythm strip without any calculations, and you can calculate the corrected QT by looking at the QT calculated in seconds divided by the square root of RR interval in seconds. So you need to look at the QT time given divided by the interval RR and square root of that. Normal values, anything less than 450 is considered sort of safe range. To be precise, for males it's less than 440, for females it's less than 460. Borderline is considered 460 to 480, but predominantly if you ask cardiologists, they will be really worried if the QTC corrected one is above 500 millisecond, because then there's a very high risk of torsades and arrhythmias and malignant arrhythmias. The two commonest groups of causes are the congenital and metabolic, and the drug-induced. In terms of drugs, a lot of common medications, antimicrobials like quinolones, macrolides, azithromycin, clarithromycin, a lot of antiarrhythmic drugs like sotalol, amiodarone, quinidine, antipsychotics, haloperidol. That's why in elderly patients, using haloperidol for sedation or for their acute delirium can be very risky. Similarly, quetiapine. Antiemetics like ondansetron and domperidol. So all of these are very, very commonly used drugs. And to be honest, whenever you are prescribing these in patients who are high risk, always check the baseline ECG for a corrected QT interval. Metabolic and congenital, a lot of electrolyte abnormalities, hypokalemia, hypomagnesemia, hypocalcemia, all of them can potentiate and even cause the corrected prolonged QT interval. Hypothyroidism is similarly congenital long QT syndrome, Romanov ward, and some of these syndromes can also contribute to the prolonged QT. In terms of the potential arrhythmias, ventricular tachycardia can prove, especially polymorphic VT, we'll come to that in a moment. That's why if there is a prolonged QT above 500, you need to check all these electrolytes and replace them as best as you can to minimize the risk and stabilize the cardiac membrane. This next slide is a diagrammatic representation from life in the fast lane, which beautifully describes the different segments. But if you look at the QT interval, the one highlighted in green, it's from the start of the QRS complex, includes the whole QRS complex, and it includes the ST segment and the T wave until the end of the T wave. So this is the QT interval for clarity. So let's look at a real life ECG for prolonged QT. So the top trace or the 12 lead ECG shows a prolonged QTC with more than 500 millisecond, and hence it's a very high risk for polymorphic VT, which is reflected in the lower two insets. You have the normal rhythm, and eventually sometimes you get what is called an R on T phenomena, R wave superimposing on the T wave. So when the depolarization wave is interposed on a repolarization phase, that degenerates into a malignant polymorphic VT. And in this situation, you can see the degeneration, and eventually it can also lead to sudden cardiac arrest. So the key step will be intravenous magnesium, removing the QT prolonging drugs, checking and correcting all the electrolytes. Our Burgundy beetle, the tachy beetle, shows a risk of malignant arrhythmia in this situation, and it's really, really crucial to be proactive in managing such patients. And finally, my pro tip, step number 10, comparison with the old ECGs. Honestly, believe me, this is probably one of the most important and one of the most overlooked parts. How many times on my clinical rounds I have seen my residents asking me, oh, there's an ECG abnormality, this is this, and the patient is totally asymptomatic. And the moment we just look at the comparison with the old ECGs, which were a few months or a few weeks ago, and they're pretty much exactly the same aerodynamic fixed changes, that just solves the puzzle. So why is it important? Because it could be revealing either a new ischemic changes or a revolving ischemia, or it could be a resolving ischemia. There could be subtle ST changes which were missed in isolation. Also, it can identify the dynamic T wave changes, because if you've got dynamic changes like the valence phenomena, valence inversion, so that indicates there is an ongoing myocardial ischemia, hence the serial troponins and serial measurements of ECG will be really, really crucial. If it's a new left bundle branch block, consider it as a diagnostic criteria for acute MI unless proven otherwise, especially if a patient is symptomatic or has got high risk factors. Comparison of the QT intervals, we just discussed recently in a couple of slides ago about the QT interval. So what was the sequential QT interval before and after the initiation of antipsychotic medications, etc. So that's one of the best uses of the old ECGs to compare the serial QT intervals. And also you can look at the rate and rhythm changes and axis changes over a period of time. So basically you're looking at the old ECGs in summary. For rate and rhythm, the axis shift, as we just discussed, looking at the P wave change, the PR interval, QRS interval, ST and T wave, and QT. So basically all the steps that we had said, you just need to sequentially compare and you will get a hell lot of information, really, really useful information for the patient's care.